Thank you very much. Good morning. It's a pleasure and an honor to be here. As these slides get loaded, my talk this morning, the first talk, is going to be a literature review of literature from 2021. Let's see if we can get loaded up. Fantastic. This is great. This is perfect, actually. So I have nothing to disclose. I have funding from the National Institutes of Health in the United States and the Gerber Foundation. So it's a daunting task to be asked to present about sort of the best studies in a year in our field. There's absolutely no way that we can include every outstanding study that was published in 2021. It's not meant to be a systematic review or comprehensive review of every study that was done in pediatric emergency medicine. But I do want to tell you a little bit about my methodology. I went on to PubMed, which is our national library search engine, and I performed a comprehensive literature search. I polled my colleagues in pediatric emergency medicine, and then I reviewed all the studies for this talk based on their methodological rigor, based on their clinical applicability, and based on their variety of topics. We could easily have filled this talk with studies of pediatric COVID-19, but I chose not to do that and included one study that I think is critical to our initial treatment of COVID-19, but for the rest of the studies included a variety of topics. Important to consider is the case most studies are definitive practice change, gives us food for thought about how we continue to practice in the pediatric emergency department. So the first study that I'm going to present is entitled Association of Oral Corticosteroid Bursts with Severe Adverse Events in Children, and this was published in JAMA Pediatrics. This study sought to identify the association of corticosteroid bursts with severe adverse events, including GI bleeding, sepsis, pneumonia, and glaucoma, known complications of immunomodulatory agents such as corticosteroids. This was an administrative database study. So this occurred in Taiwan. They used their National Health Insurance Research Database over 4 years, from January 2013 through December 2017. The exposure was an oral corticosteroid burst, and it's important to understand how this is defined. In this study, this was defined as a burst of corticosteroids over a 14-day period. So longer than our typical treatment of, let's say, an acute asthma exacerbation, as Dr. Shah talked about yesterday, but still typical within sort of a typical burst of steroids for other conditions. They studied 4,550,000 children. And of those children, 1 in 4 received an oral corticosteroid burst. So about 1 million kids. And what they found was that among these children, the incident rate ratios, or IRR, within 5 to 30 days after initiating a corticosteroid burst was 1.14 for GI bleeding, 2 times increase for sepsis, 2 times increase for pneumonia, and no change for glaucoma. And what's important, you can see that increased risk. Oh, let's see. It's not quite showing, but I can, if you look at the dots that are towards the right side of the screen, the squares, you can see the increased risk in the 5 to 30 day. But what you can also appreciate is that by days 31 to 90, that this risk was attenuated and there was less risk in that period of time. And so the conclusion from this study is that corticosteroid bursts in the immediate period, the immediate month after receiving the burst, was associated with a 1.5 to 2.5 fold increase risk of GI bleeding, sepsis, and pneumonia, but that risk is then attenuated for the subsequent 31 to 90 days after. The next study was actually published by my colleague at Lurie Children's Hospital Chicago, Mary Clyde Pierce, who is really an internationally known expert in the field of child abuse. And this is a really important study. And this, I do consider this to be a practice-changing study. This was a validation of a clinical decision rule to predict abuse in young children based on bruising characteristics. This is a common presentation. Kids present with bruises all the time. And the clinical challenge for us in emergency is to be able to differentiate accidental bruising from non-accidental bruising. And so the objective of this study was to refine and validate a previously derived bruising clinical decision rule. This was done as a prospective cross-sectional study over 5 years at 5 urban children's hospitals in the United States. This was the rule that was validated. And you can remember the rule by an easy mnemonic, 10-4 faces P. And so the 10 stands for torso, ears, neck. These are places where children should not be routinely bruising. So if you see bruises in the torso, the accidentally. Similarly, the 4 is 4 months or younger. Any bruise anywhere on a 4-month-old baby or younger should be considered suspicious. And then patterned bruises is the P, bruises in specific patterns, hand marks, belt loops, that sort of thing, plugs. And so 10-4 faces P was the rule. And what you can see here is that the BCDR, the bruising clinical decision rule, was highly sensitive, 95.6% sensitive and 87.1% specific for distinguishing abuse from non-abuse based on these body regions. And so in this study, the conclusion is that an affirmative finding of any of 10-4 faces P should be considered as potential risk for abuse. The next study, entitled Serum Sodium Concentration and Mental Status in Children with Diabetic Ketoacidosis, or DKA, was published by our colleagues in the Pediatric Emergency Care Applied Research Network, or PECARN, as part of a randomized trial of fluid speed and fluid concentration in resuscitating children with DKA. And in retrospective studies, the background for this is that researchers have found associations between serum sodium declines during DKA resuscitation and cerebral injury. And so the goal of this study was to prospectively investigate the determinants of sodium concentration changes and the association with mental status changes during DKA. And so they used data from this PECARN trial, and they looked at a host of outcomes, which you can see here, including GCS score, Glasgow Coma score, and then other things that are indicative of cerebral injury, digit span, other sort of memory tests. And what this study found was that declines in glucose-corrected serum sodium concentrations were associated with higher sodium and chloride concentrations at presentation, and also with a prior diagnosis of diabetes before presenting with DKA. Generally, treatment with half normal saline compared to normal saline was also associated with declines in serum sodium. However, what this table shows is that there were no differences in neurological outcomes at 4, 8, or 12 hours after presentation in those children whose glucose corrected sodium remained stable or increased versus those that decreased. So changes in glucose corrected sodium during DKA treatment are influenced by the balance of free water versus sodium loss and the sodium content of the intravenous fluids that's used to resuscitate. And declines in glucose, this is a bit of a myth buster because this study did find prospectively that declines in glucose-corrected sodium concentrations are not associated with mental status changes during resuscitation for diabetic ketoacidosis. So this next study, very important study, Dr. Gaucher-Hill is on this study as a co-author. And this study looked at the evaluation of emergency department pediatric readiness and outcomes among U.S. trauma centers. This is a critically important study because we know that 85% of children who seek emergency care in the United States seek emergency care at general emergency departments or community emergency departments that are not pediatric specific emergency departments. And so the work of Dr. Newgard, Dr. Gaucher-Hill, and others, many others, has looked at developing a pediatric readiness score to ensure that community emergency departments, general emergency departments are fully prepared to care for children across the age spectrum and across the severity spectrum. And what this study found, importantly, was that children in the highest quartile of pediatric readiness EDs, so those EDs that are most well prepared to take care of children, labeled as the fourth quartile here, were significantly less likely to have mortality, high injury severity scores, high abbreviated injury scores, and higher resource needs, to have decreases in mortality the more ready they were in terms of pediatric readiness. And that showed for mortality, but not for complications, which you see on the right side of this screen. And so in this cohort study, the conclusion was that injured children that were treated in high readiness EDs had lower mortality compared with similar children in low readiness EDs. And that if children cared for in these lower readiness EDs were cared for in highest readiness EDs, that an additional 126 lives might be saved every year by increasing pediatric readiness at these general EDs. Critically important. Oops, sorry. So this is the one COVID study that I promised you. This was published in the New England Journal of Medicine about multisystem inflammatory syndrome in children, initial therapy and outcomes. And this study looked at surveillance data on inpatients younger than 21 years of age who had MIS-C and were admitted to one of 58 US hospitals in 2020. And this study evaluated the effectiveness of IVIG plus glucocorticoids versus IVIG alone. And what you can appreciate in the propensity score matched analysis and in the inverse probability weighted analysis was that IVIG plus glucocorticoids were better in outcomes of cardiovascular dysfunction and secondary outcomes of left ventricular dysfunction, shock requiring vasopressors, adjunctive immunomodulatory therapies, and persistent or recurrent fever. So that this study concluded that among children in adolescents with MIS-C, that initial treatment with IVIG plus glucocorticoids was superior over IVIG alone. And in fact, this has informed practice, and certainly in our center, this is the initial standard treatment, this combined therapy for children with MIS-C. This study was published by the NEAR investigators, or the National Emergency Airway Registry, which is an observational 25-center registry of ED intubations. This is an adult study, but went down to 14 years of age and has weight-based dosing of rocuronium. So I thought it was relevant to our pediatric population. And what this study looked at was 8,034 rapid sequence intubations. And they looked at the doses. The standard dosing of 1 milligram per kilogram, 1 to 1.1, 1.2 to 1.3, and 1.4 milligrams per kilogram of rocuronium. And what this found was that first attempt success rate was higher in those that received 1.4 milligrams per kilogram of rocuronium or greater compared to the standard dosing of 1 milligram per kilogram of rocuronium. And so this concluded that rocuronium dosed at greater than or equal to 1.4 milligrams per kilogram was associated with higher first attempt success when using direct laryngoscopy with no increase in adverse events. And what's interesting, if you look at the graph on the right, is that video laryngoscopy, and indicated by the line in red, there was no difference across dosing, but this difference was seen with direct laryngoscopy. Again, this is a retrospective study, not meant to change our practice immediately, but things that make you go, So the next study was, I cheated a bit. This was published in early of this year. Videographic assessment of tracheal intubation technique in a network of pediatric emergency departments, a report of the Viper Collaborative. The Viper Collaborative is an outstanding multi-center collaborative in the United States of video review. So these institutions have continuous video recording in their resuscitation bay to be able to look at a whole host of outcomes in critically ill children that present to the emergency department. And this study looked at data from 494 intubations. The first attempt success rate was 67%. The median laryngoscopy duration was 35 seconds, and hypoxemia occurred in 15% of the patients. What this study found was that attempts in which video laryngoscopy was used for the entire procedure compared to direct laryngoscopy had a longer duration. So the difference in medians was 6 seconds longer with a 95% confidence interval of 1 to 12 seconds. And intubations longer than 45 seconds, so blade in the mouth for more than 45 seconds, had a greater incidence of hypoxemia versus shorter time of blade in the mouth. So 29% incidence versus 6%. However, what you can see here is that there were no differences otherwise in terms of success rates or the incidence of hypoxemia. So the conclusion was that video laryngoscopy use was associated with a longer laryngoscopy duration, however, was not associated with the success rate, first pass success rate, or with the incidence of hypoxemia. The next study, we talked about a little bit in our panel discussion yesterday on PCR testing and antimicrobial stewardship, was a randomized trial that looked at the effect of rapid respiratory viral testing on antibiotic prescribing among children presented to the emergency department with acute respiratory illness. This is a topic near and dear to my heart and my professional passion. This was a really great study. They randomized participants to either have the clinicians receive the results of a multiplexed PCR testing or to use standard care without the results of multiplexed PCR testing. And they found some really interesting results. They looked at 931 ED visits, 452 children in the group that received the results, and 452 in those that did not. And what they found was that after propensity score weighted analysis, that children with test results were more likely to receive antivirals, 2.5 times more likely to receive antivirals. And you can see that in that first column on the left in prescribing oseltamivir. You can see that after the results came back, that providers were more likely to provide oseltamivir, but that interestingly, there were no difference in antibiotic prescribing. So knowing the results of a rapid respiratory multiplex PCR panel did not change physician antibiotic prescribing behavior. This study, I think, is also a single center study. It has those limitations, but it's very important and relevant to our care. Dr. Vittal spoke about high flow nasal cannula yesterday during his talk on respiratory failure. This was a single center study at Cincinnati Children's Hospital Medical Center that looked at trends and outcomes in high flow nasal cannula use in a pediatric emergency department. This is a retrospective cohort study of children 2 to 24 months of age. Primary outcome was high flow nasal cannula initiation. The secondary outcomes were things like admission rate, ICU admission, transfer to the ICU after arriving on the general inpatient ward, and endotracheal intubation. And they performed an adjusted interrupted time series analysis to look at changes over time. And what they found was that in 11,149 children with bronchiolitis, 902 or 8% were initiated on high flow nasal cannula in the ED. And that the rate of high flow nasal cannula initiation increased from 1.3% in 2012 to 2013, all the way to 17% in 2018 to 2019. And importantly, less than 30% of children that were initiated on high flow nasal cannula were hypoxic. So 70% of children did not have hypoxia that were started on high flow nasal cannula in this cohort. And what they found in terms of outcomes was that there were no significant, despite this 13-fold increase in the use of high flow nasal cannula over this period, there were no significant changes over time in admission, PICU admission, transfer to PICU, or intubation. So they found a 13-fold increase with no evidence of improvement in clinically meaningful outcomes. And I think this suggests that we really need to look very closely at our use of high flow nasal cannula as a therapy for bronchiolitis in the emergency department. And really, we need better predictive tools to be able to assess which children are most likely to benefit from the initiation of high flow nasal cannula in terms of meaningful outcome change. This study is the SCOUT-CAP trial, or short course versus standard course outpatient antibiotic children for community-acquired pneumonia in children. I cheated on this too. This was published in early 2022, but there were 2 other studies, one out of Canada and one out of the UK, that were published in 2021. So I felt that I wasn't cheating that much by including this study in this summary. And what this study did was a randomized trial to compare 5 days versus 10 days of amoxicillin in children with outpatient mild community-acquired pneumonia. They randomized. How many children did they randomize? They randomized 380 children to short course versus long course. And what they found is they found no differences when you look at all of these individual outcomes, that That vertical line down the center means no difference. You can see that all of the confidence intervals cross that vertical line. And so they looked at clinical response, persistent symptoms, antibiotic-associated adverse events. And when you looked at those individually, there were no differences between short course and long course. But importantly, they used a composite outcome that noted that for patients with the same clinical outcome, if you got more antibiotics, you got dinged. If you got more antibiotics, that was considered a negative thing in children with equivalent clinical outcomes. And when they looked at that outcome, they found that the children that received short course, 5 days, had a 69% probability of a more desirable outcome compared to standard course strategy. And so in this study, the conclusion was that among children responding to initial treatment for outpatient pneumonia, that a 5-day antibiotic strategy was superior to a 10-day strategy, and that the shortened course resulted in similar clinical response and antibiotic-associated adverse effects while reducing antibiotic exposure. And the super cool thing about this study is they did nasal swabs of all of these children to look at resistance genes in the nasopharynx. And they found that actually there was decreased expression of resistance genes in those children that received 5 days versus 10 days. So this suggests that a shorter course has similar clinical outcomes, but has a meaningful ability to decrease antimicrobial resistance in the acute management of kids with pneumonia. And this is the last study that I will share. This is the study that Dr. Nigrovich had just presented, Predictors of Invasive Herpes Simplex Virus Infection in Young Children. Dr. Cruz from Dr. Shah's institution is first author. And this was a study of the Pediatric Emergency Medicine Collaborative Research Committee. This is actually the sort of research arm of the section of emergency medicine at the American Academy of Pediatrics. And this was a study of 23 centers, a nested case control study that was executed within the Pediatric Emergency Medicine Collaborative Research Committee. And this study found, as Dr. Nigrovich shared, that this study developed a risk for invasive HSV in young infants. And the odds ratios or beta coefficients of the score that Dr. Nigrovich presented were then converted to a points-based system, which you can see here on the left. And if you had a score that included younger age, seizures at home, and ill appearance, abnormal triage temperature, which is defined as a temperature of 38 centigrade or greater, or less than 36.4 degrees centigrade as a definition for hypothermia. A vesicular rash, thrombocytopenia defined as a platelet count of less than 150,000, CSF pleocytosis defined as a CSF white blood cell count of greater than 15 cells per millimeter cubed if less than 28 days, or more than 10 cells per millimeter cubed if greater than 28 days, and then prematurity defined as birth before 37 weeks gestation. And if you had a score of 3 or more, that score had a sensitivity of 95.6% and a negative likelihood ratio of 0.11 with an area under the receiver operating characteristic curve of 0.854, suggesting that a score of less than 3 suggests that we can identify a group of infants at very low risk for invasive HSV infection using this score. So some takeaway points from this whirlwind tour of pediatric emergency medicine literature in 2021. Corticosteroid bursts were associated with a 2-fold increased risk of GI bleeding and sepsis and pneumonia within the first month that was attenuated. 10-4 faces P it can be used to identify non-accidental bruising based on body region, infant 4 months or younger, or patterned bruising. Declines in glucose-corrected sodium concentrations are not associated with mental status changes during DKA treatment. Injured treatment that are treated in high readiness EDs for children had lower mortality compared with similar children in low readiness EDs. Among children and adolescents with MIS-C, initial treatment with IVIG plus glucocorticoids was associated with a lower risk of new or persistent cardiovascular dysfunction than IVIG alone. A higher dose of rocuronium was associated with higher first attempt success using DL among patients with pre-intubation hypertension and no increase in adverse events. That video laryngoscopy was associated with longer duration of laryngoscopy, but showed no differences compared to DL in success or incidence of hypoxemia. Multiplexed respiratory PCR testing does not change antibiotic prescribing behaviors for respiratory infections, but does increase the rate of antiviral treatments. High flow nasal cannula use has increased more than tenfold over time with limited changes in clinical outcomes. Among children responding to initial treatment for outpatient pneumonia, a 5-day antibiotic strategy was superior to a 10-day strategy. And finally, we now have an HSV risk score for invasive HSV infection in young infants that consists of younger age, seizures, ill appearance, abnormal temperature, vesicular rash, thrombocytopenia, CSF pleocytosis, and prematurity. And with that, I will hand it off to the next speaker. Thank you very much.